I'd like to thank the Indiana Rural Health Association for allowing me to present on rural health clinic billing. We are going to focus today's presentation on Medicare billing of rural health clinics. We're going to talk about the basics. I know IRHA and I have just had a conversation about having this education session focus in more on the basics, and maybe when we go back to our November conference that we can add additional advanced billing questions or services. We can get in a little bit about documentation, the advanced billing for example, hospice providers, additional routine care. But today we want to take it back and say, you know, what is a rural health clinic? What are the differences between independent and provider-based rural health clinics? How to bill for those basic rural health clinic services, whether that service be on a UB format, is it on a 1500 bill? I'm going to give you some examples on how the claim should look. And we're going to touch a little bit today about the new telehealth rules and regulations as it relates to Medicare. I don't have a lot of focus on Indiana Medicaid in response to this presentation that we're doing today, but I can tell you that in the past few days or past actually couple of weeks, there have been several Indiana live presentations that you are able to go to the Indiana Medicaid website and download in regard to telemedicine services, if I'm going to put it in the same definition that Indiana Medicaid does. But I'd be more than happy to answer any questions that you have in regards to the billing, but I want to let you know that the focus of the presentation is truly based upon Medicare guidelines. Back in 1977, they established the Rural Health Clinic Services Act. If you can believe, it's been 43 years since rural health clinics have been established. And I will say, since that time, all services have always been face-to-face services. And when the act was developed, it was developed based upon a service that was rendered by a rural health clinic provider, medically necessary service, and that the service was face-to-face. So now, you know, here we set it in 2020, and we are receiving payment for true telehealth services. So I'm very excited about that. I'm excited about what the next year may bring to us as it relates to rural health clinics and the expansion of rural health clinics outside of the pandemic and what it can bring to the rural communities and the providers. But the reason why they started the rural health clinics was that in rural areas, there just were not enough providers to provide a service. So they wanted to provide some type of enhanced reimbursement to those providers so that they could provide services to rural members. Now, I think my slide's a little bit outdated. There's 80 plus rural health clinics across Indiana, whether that be freestanding or provider-based, but it is a national development of the rural health clinics. There are a lot of members. You have your Indiana Association for the Rural Health, and then you have your National Association of the Rural Health Clinics. If you're a rural health clinic already, you are already located in a non-urban area, or it's considered rural, based upon the IRHA website. There are geographic indicators to say that you're a rural health clinic, and based upon the rural health clinic, you have to be located in a HIPSA, an MUA, a geographic HIPSA, or in a governor's shortage area. I will say that many of you that are already rural health clinics, you know you have to be in a geographic or a HIPSA or an MUA. But I do want to say that if you are in a situation to where you do have to move the rural health clinic, you would want to go back and look at the IRHA website to ensure that the location that you're in or that you want to move to continues to be in a MUA or in a HIPSA, because if it has not been updated within the last 4 years and you move your rural health clinic to another location, and it's no longer in a designated area in the last 4 years, then unfortunately you will lose rural health clinic status. So that is something that you do want to keep in mind, that should you move your rural health clinic or need to move to another location. Common services that are provided under the rural health clinics are those evaluation and management services, primary care services. You're providing emergency services, and you have the materials available to provide those emergency services. That 51% of your services that you are providing through your rural health clinic are primary care services. From a designation standpoint, Medicare does consider family practice, internal medicine, pediatrics, and OBGYN a designation of primary care. It is possible for you to have specialists located within your rural health clinic and to bill for those services as rural health clinic services. The rule, though, is that 51% of the care that's produced through the rural health clinic must be provided by your primary care providers. And that you do have diagnostic or laboratory services included on site. Those laboratory services are listed here on the page. I will tell you that it is a requirement for you to be a rural health clinic for you to have the availability to provide these services. I know many rural health clinics do have established relationship with lab companies, and that through this establishment, they will have the lab company employ a person to provide laboratory services. And that's perfectly fine for that to happen. But unfortunately, based upon the rural health clinic's designation, you also have to have these services available so that you can do them at any time. So I'm going to give you an example. You have a contract with a lab company. That lab individual is supposed to come in today, but she's sick. So at that point, let's say they don't have another person to fill in. You still must meet the requirement to provide all of these 6 services to your member that day, even though that contracted individual through the lab company is gone. So you must have the availability to provide these services, these 6 lab services. Now, I do also want to say that it's a little bit different in the fact that to become a rural health clinic, you must provide these services. But CMS has made it a regulation that it's not a CMS covered reimbursement benefit as a rural health clinic to be reimbursed for laboratory services. They are a covered benefit, but not under the rural health clinic regulations. They're covered under the Medicare fee schedule benefit and must be filed for or claimed as a fee schedule benefit. You cannot claim them as a rural health clinic visit. I have seen where in review of old or update audits and looking at claims and how rural health clinics have billed their services, it could be that I could see an evaluation and management and I could see a blood sugar on the UB bill because people just didn't know that they could separately bill for those laboratory services to the Medicare Part B program under the fee-for-service benefits, or if you're provider-based, under your main entity's claim form to file for a claim. So I do want you to know, even though it's a requirement to provide the service, it is not a benefit reimbursable under the rural health clinic rules, reimbursable under another set of rules. To be a rural health clinic, you must have a nurse practitioner or a physician assistant, could be a certified nurse midwife as well. And 50% of the time that the clinic's open, you must have one of those mid-level providers available as the rural health clinic operates. Again, you can have a specialist. It could be in your community. Maybe you have a need for a pulmonologist. It's absolutely appropriate and fine for you to contract a specialist, have them come into your rural health clinic, provide services, and then bill for those services as rural health clinic services, just as you do your primary care providers. But we do have to go back to that one rule that I told you, and which was 51% of the overall care provided to the patient must be primary care services. Again, that primary care is in internal medicine, family practice, pediatrics, and OBGYN. To be a rural health clinic, you have to have a quality assessment program, and that's pretty much what are you going to do in this case from a clinical perspective. That it could be that your physician, your nurse practitioner, you have protocols, and what are your protocols for your quality clinical improvement opportunities? You must post your days of operation in the front of your building. To be a rural health clinic, you can't be designated as something else. For example, a federally qualified healthcare center or a rehab facility or a community mental health center. You can only have the rural health clinic designation. And you must meet all state requirements. For example, in the state of Indiana, for a rural health clinic, you must be registered with the state of Indiana to be a rural health clinic provider. So you must be registered through the Secretary of State to be a rural health clinic. There are two types of rural health clinics, independent and provider-based. We use those terms interchangeably. Independent meaning that you're primarily owned by a physician group, and provider-based, for the most part, you're owned by a hospital. In the freestanding or independent, again, the majority of you are owned by independent physician practices. You do receive a capped reimbursement rate. This year for 2020, it's $86.31 a visit. For the independent rural health clinics, the way that you bill for your technical components or your lab services or your diagnostic services are going to be just a little bit different than your provider-based partners. For the provider-based rural health clinics, you're paid at the all-inclusive rate or based upon your actual cost. That is, if you are owned by a facility, and that facility could be a critical access hospital, acute care hospital, a skilled nursing facility can own you, a home health agency can own a rural health clinic. If the owner is under 50 beds, and that's staffed beds, then you receive the all-inclusive rate for your reimbursement of a rural health clinic. Let's say a hospital owns you, it's an acute care hospital, and they have 100 beds. You can still be a provider-based rural health clinic, but your reimbursement will be capped at the freestanding rate or independent rate of $86.31. So the advantage in being a provider-based rural health clinic is that the owner of the rural health clinic, for example, the critical access hospital, is under 50 beds because critical access hospitals only have 25. So you receive your actual cost per visit. Those laboratory components or diagnostic services, they're going to be billed just a little bit differently than the independent partners. So those of you that know me know that there are three things that are out there in regards to a rural health clinic. And a lot of times I'll come back and I'll say, have you met the definition of the rural health clinic? And that definition, I want to focus on three different things. For a rural health clinic encounter, it has to have a medical necessity component. Is the service medically necessary? Did you provide the services face-to-face? And were those services provided by what's considered a mid-level provider or a provider of the rural health clinic? It can be a physician, an MD or a DO, a nurse practitioner, a physician assistant, a certified nurse midwife, a clinical psychologist, clinical social worker. Now, if the service that's provided is provided face-to-face, it was medically necessary and provided by one of those provider types, you do have a rural health clinic encounter. And I guess we could add on another thing, and the other would be that the service is actually performed at the rural health clinic. So there are services that are not considered rural health clinic services. It's not considered an encounter or a billable, reimbursable service. And that's patient just comes in just for lab results, or patient just comes in for an allergy injection. Because that service may be medically necessary, it also may be provided at the rural health clinic. It also may be provided by an individual that works underneath the mid-level provider or the practitioner, physician assistant, but the service was not face-to-face with that individual. And if a patient came in only for an allergy injection, only had services rendered by the medical assistant or the RN, the LPN, for example, the LPN provided the allergy shot, patient waited 20 minutes. There was no indications, no reactions or anything like that. Patient sat out in the waiting room and then they went home. That's not considered a rural health clinic encounter because it did not meet that face-to-face service with one of those reimbursable providers. On the other hand, I have an example here of a nurse visit is not a rural health clinic encounter. However, if those nursing services do go back to meet those three things that I told you about, medical necessity, face-to-face, and done by that provider type, then it can turn into a rural health visit. For example, let's say the physician says that he wants the patient to come in every week for the next month to have a blood pressure checked. In actuality, that's a nurse visit. But what has happened is now we're on week 2 of the blood pressure check and patient continues to have high blood pressure. The medical assistant or LPN, RN goes back to the physician and says, patient's blood pressure has been up now, in the last 2 visits or 2 weeks that they've come in. What would you like to do? Maybe the physician says, I need to talk to the patient. We need to have a conversation. It could be that there's something else going on. So now that reason for the patient coming in just to get their blood pressure checked now turns into a face-to-face visit. Then you would bill your appropriate evaluation and management code. But for patient just to come in to have a blood pressure check, everything was normal and then they were sent home is not a rural health clinic encounter. Rural health clinic services, they're billed on a UB format or a CMS 1450. In the UB format, we go from 711, which is the original claim that we submit to Medicare, to a 718, which is a canceled claim. There are times where you would do an adjusted claim, and in that adjusted claim, it could be that you want to add additional services to the claim that was originally omitted. There is also, from the place of service, and I apologize, I'll have to update this piece of information, but the place of service for rural health clinics is 72.
Hey. Yeah. What time?
I will tell you that place of service 72, a while back, and I'm going to say years back, I used to work for Medicare. And in working for Medicare at that time, they had system edits that were in place. And those system edits are actually beneficial to you. With those, what I mean by that is, why is it beneficial? Because the system edits are set up to say, if you had a service that went into the Medicare program and it was on a 1500 claim form, so let's say these are services that are not considered rural health clinic services. Common non-rural health clinic services refer to labs, technical components of a diagnostic test, services that are not provided at the rural health clinic or designation of a rural health clinic are filed to the Medicare Part B program. And in filing to the Medicare Part B program, that would be on a 1500 claim form, would have that place of service 72. Medicare does have edits that are built within the system. Let's just say, for example, you tried to bill the Medicare program on a 1500 claim form with place of service 72, and you attempted to bill a drug, a J code. That claim should deny because Medicare has the claims system set up appropriately that they know that drugs are considered rural health clinic service. And if you filed it with place of service 72, the claim should deny, saying you need to file in the appropriate claim format, which would be on your UB claim. And we're going to get into several examples of the UB claim. The differences in billing as it relates to freestanding or provider-based is going to be on your laboratory services and your technical components. For both independent and rural health and provider-based rural health clinics, your rural health clinic services are going to be billed in a UB format. The difference is your laboratory. If you're an independent rural health clinic, you're going to bill on a 1500 claim form for your laboratory services. If you're provider-based, you're going to bill under your parent entity, which is what is the entity that actually owns you. And the example I gave earlier was that critical access hospital. If that's the case, the laboratory services are going to be billed under the critical access hospital. The only thing that is going to be separate is that venipuncture. Back in 2014, Medicare told us that the venipuncture, the 36415, is actually part of the rural health clinic service. So we would want to have that under our UB bill type, 300 36415. And then the technical component of non-RHC services. And what I mean by that, many times what's applicable to this category would be EKGs. If you performed an EKG, which has a technical component and a professional component, the technical component is not a rural health clinic benefit, but it is a reimbursable benefit, but just under a different Medicare policy. So that would be billed. If you're independent, that's going to be billed on a 1500 claim form and separately reimbursable. I do have an example of this. If you are a provider-based, you're going to be billing that under in the example I gave, the critical access hospital will be billing for that technical component. And again, we are going to go over this example. There are revenue codes that must be used on your UB claim. Many times the biggest component that you're going to use is your revenue code 521, which is the services were rendered at the rural health clinic by a rural health clinic provider, meaning the MD, DO, NP, PA, etc. Or you may do the SNF or nursing facility, the 524 or 525. When services are rendered by your rural health clinic practitioner, all the provider types, when they see a patient at a skilled nursing facility or at a nursing facility, that is considered a rural health clinic service. Another common revenue code would be 900, and that's for a mental health service. That's a common revenue code. Now that 528, which is a rural health clinic practitioner providing a service elsewhere than the rural health clinic site, I've only used that once, and I will say I've been involved in the rural health clinics for over 20 years. And again, I've only billed it once, and that's where a rural health clinic was located at a stoplight, and there was an accident at the stoplight. The rural health clinic practitioner ran to the stoplight. It just so happened to be that the patient was a patient of the rural health clinic. But the practitioner of the rural health clinic, they provided a service at the scene of an accident, so they were able to bill that revenue code 528. But I've only billed it once. I know several people that have never had the opportunity to bill for that service. But the main ones that you will use would be 521, services provided at your clinic, 524 or 525. And that means that 524 or 525, that the services were rendered at the skilled nursing facility or the nursing facility. Other common revenue codes that are provided on the UB claim that goes to Medicare Part A on the UB, it's going to be that revenue code 250 for drugs, or that 300 that we talked about for the venipuncture, and that's under your 36415. Your drugs that are administered to the patient, and then revenue code 780, the telemedicine originating site, that will go on your UB claim for your originating site fee. Remember, that's with your Q3014. Hopefully those rules will be changing. And just I hope Medicare will see the value that rural health clinics do provide in telemedicine services, and I'm hopeful that the 780 will change. So we shall see. On rural health clinics, back in 2016, they told us that you need to start line item coding your services, meaning you need to tell us line by line on our UB claim, what did the patient have performed during the course of the visit? And everything that's defined by an individual CPT code should be on your claim. They also told us that you had to have what's called a qualifying visit. Well, CMS started a list of what they had designated as a qualifying visit. Then what happened was that there were all these CPT codes that were being added, and CMS was continually updating this list until finally CMS said, we're no longer going to update the list. So if you do a search on rural health clinics and a qualifying visit list, you're going to see a lot of evaluation and management services that are on there. You may see some chiropractic services that are on there. You may see routine care that's on there. But I can tell you that CMS stopped updating this list. CMS came back to us and said, we need you to determine, was the service medically necessary? Did you provide the service at the rural health clinic? Was the service provided face-to-face? And was it done by a reimbursable provider? If all those things happen, we want you to tell us that the services met those conditions and that we're going to go ahead and we're going to pay the claim. You're going to apply what's called a CG modifier. And by applying the CG modifier, you're saying that the service was medically necessary, face-to-face, and by that provider type. You're also telling Medicare, I want you to apply coinsurance and deductible based upon the dollar amount on this line of the UB claim. And so I'm going to show you an example of that. I know it's kind of hard to see, so kind of bear with me just a little bit. And kind of look in a little bit, you can see. But in this example, we have a patient who came in for an office visit, a 99213. That 99213 charge is actually at $100. They had a procedure performed at the same time that they had their visit with the physician, and then they also had a drug. So what we've done by the 3 lines is that we've said the patient had an office visit, they had a procedure done, and they had drugs. But CMS wants us as rural health clinics to do what's called a roll-up. In that roll-up, they want us to include all of these services or all of the charges onto one line. So that's why you will notice that the first line is a charge of $170. That charge adds in the office visit of 100, the procedure of 60, and the drug of 10. So the total of that encounter is $170. By applying the the CG modifier, you are actually telling Medicare, I want you to take coinsurance and deductible from $170. Now keep in mind that patient coinsurance is based upon your total charge. If you are a provider-based rural health clinic, independent rural health clinics, they usually detail out their charges, meaning the 100, the 60, and the 10. If you're provider-based rural health clinics, it is very common for us to see that the secondary lines, for example, in this on this claim, the secondary lines would be a penny. So in my examples, I give total charges all throughout the document, but it's absolutely appropriate for provider-based for you to have a penny for your line item charges outside of your CG modifier. And the reason for that is that the roll-up makes it appear as if the patient's being charged more than what they were actually charged. So when they get their EOB, kind of looks a little different. So a lot of provider-based did switch to a penny, but I do not suggest independent provider-based, or excuse me, independent rural health clinics itemize out their charges and only provide a penny for the second one. The reason for that is that you want to show all the services and the amounts and charges of your services, so that at one point in time, as the National Association and the Indiana Association fight for you in getting higher capped rates or higher rates, that they can show the detail of actually how much it costs you and what is the average pricing for that particular service. So there is a question that has come back, and for provider-based rural health clinics on the UB, box 1 should be the rural health clinic. Yes, box 1 should be the rural health clinic, and box 2 should be the name of the facility that does own the clinic. That is correct. I will say I was just researching something prior to jumping on this this call, and I will say that there's been a lot of questions of late in regards to how to fill out the UB and what is field locator number 1 and what is field locator number 2. And for those provider-based, for the most part, provider-based entities, CMS did have location edits that they were going to turn on. This does not affect the independent rural health clinics, but for provider-based entities, the multiple service location, CMS has announced on April 30th that they have delayed those edits, so they did not go into place, and they have not notified us when those edits will be turned back on. So just a little bit of, I guess, different information. But on your claim example, so patient came in, and when patient came in, they just had an office visit. So our total charge would be $100. We would make sure to apply our CG modifier with our revenue code 521. There were no additional services, so our UB lines should look in field locators 42 through 47 should look similar to this. If patient came in just for a procedure only and there was no evaluation and management, that's okay. That particular code may not be on this old qualifying list, but like I said, CMS is not updating the list. You're saying that you've met the definition. So for this procedure code, I don't think this is this simple incision and drainage. I think it's a little bit more complicated. But with that being said, you still met the definition. It was a face-to-face, it was medically necessary, and it was performed by a reimbursable provider. So in this scenario, you would still apply your CG modifier because that's the only service that was provided. There was no office visit code. The total charge was $150, and you want to take coinsurance from that particular line. But let's say when patient came in, they had an office visit and a procedure. That's when this roll-up comes into play. Remember, the roll-up is an accumulation of all your charges, or a total of all your charges that incurred on that day for the patient. So the office visit, the 99213, is $100. Your procedure code's $150. So your first line with your CG modifier is going to be your total charges for your entire claim. Let's just say that you did not perform a roll-up. So let's say in this example that the 99213, instead of it being the total charge of $250, you had a total charge of $100, and you did not perform the roll-up. The effect of that would be that you're not appropriately submitting a claim to the Medicare program, because $100, the Medicare Part B deductible would only apply to a $100 service, or coinsurance to a $100 service. So in effect, you're hurting yourself, and you could say, maybe I'm not hurting myself. Well, if coinsurance is based upon the CG line, which it is, and the vast majority of your patients have secondary insurance, and in that secondary insurance of Medicare, they're going to pick up the coinsurance and or deductible. If you do not have the appropriate dollar amount out there, you're not collecting from the secondary insurance the coinsurance that you could be collecting. So you're leaving essentially money on the table if you're not doing the roll-up. This one gets a little bit more in depth. So when patient did come in, they had their office visit, they had their administration of an injection, and maybe they had a Rocephin shot. Again, we're going to total all of those services up. In this example, the office visit for the 99214 was $150, the administration of the drug, and then the actual drug itself. We have detailed out all of the services that was provided to that patient on that particular day. There are some services that we do not want to provide a roll-up on. And when you think about it, Medicare pays 100% for preventive services. If we did actually perform a roll-up on preventive services, then it can't be paid at 100% because Medicare doesn't know how much you charge for that individual service. We don't want coinsurance and or deductible to apply to something that Medicare pays at 100%. I did provide you a couple of resource links to go to. This would be one of those sessions that we may have in the fall and have maybe a little bit more in depth, go into the well woman exam in regards to preventive services. But I do want to let you know that you do not want to roll up your preventive services. And that's your GO438, your annual wellness visit, or your subsequent wellness visit, or your initial preventive physical exam. Do not roll those services up. Line item code those separately, and do not roll them up to the line. Here's an example of that. So the patient did come in, and when they did come in, they have both services done on the same day by the same provider. We would want to separately charge for those. We would not want to add the $195 into the $150 charge. We do want to have it separate. So Medicare can look at the GO402 line and that they can pay for it at 100%. Okay, and we don't want coinsurance and deductible to apply to that. If you added it, or if you did do a roll-up, patient is going to come back to you and say, wait a minute, you told me this GO402 was 100% and I wasn't responsible for anything. So it's all in the manner of how you are going to bill for it to let Medicare know that the patient did have the service done. So do not roll up preventive services. We did talk about this a little bit in regards to there are services that are provided that are considered non-rural health clinic services, and that's those laboratory services, the technical components of diagnostic services. There's also services that are considered non-rural health clinic, and that it would be inpatient. Maybe your provider, physician, nurse practitioner, maybe they do inpatient rounding services at the hospital. Those are not considered a rural health clinic service. And so you would want to bill those outside the rural health clinic benefit so that you can receive reimbursement for those services. I know common things are inpatient services. If you have an OBGYN, maybe there's a delivery that from a Medicare standpoint, those are not considered rural health clinic services, the actual delivery itself. And you would want to go ahead and you would want to bill those separately. Just like the diagnostic services, we do want to bill separately. So in this example that I've tried to provide you today is an EKG patient came in and had an office visit and they had an EKG. We know from a coding standpoint that there's really one code for a global EKG, and that's 93000. But in this case, our provider at the rural health clinic, they read the EKG that day. Because it's a professional service, all professional services from providers provided in the rural health clinic are considered a rural health clinic service. So with that being said, the EKG has to be split between professional service and technical service. So to do that, we need to use the codes that tell us professional and technical. And the 93010 is the professional component for reading a service or reading this EKG. It is a rural health clinic service and will be billed on the rural health clinic bill. And you are going to want to roll that service up. So the charge is $25. You would want to add it to your office visit. So your total charge for that day would be $125 for the rural health clinic service. Now, of that EKG, there's a technical component. There's the machine, the tracing, that would be billed separately. And that's dependent upon if you're a provider-based or independent rural health clinic. If you're independent, the 93005 is going to go on a $1,500 bill and be billed to Medicare Part B, and you're going to receive physician fee schedule reimbursement. If you're a provider-based rural health clinic, that technical component is going to be billed under your parent entity or your main provider. The example that I gave earlier was the critical access hospital. The critical access hospital will be billing for this service, not the rural health clinic for provider-based. There are scenarios that that do allow for multiple visits on one day. Now, I do want to say this. Some people say, well, Sharon, it's possible that, patient came in to have a service and they're going to see provider A for their chronic condition, and they're going to see provider B for their annual wellness visit. For that specific example, Medicare is going to follow the secondary bullet, which pretty much says, regardless of length, complexity, number of providers seen, scheduled or unscheduled, we're only going to allow one visit per day. So those would be combined. You would bill for them separately, separate line item code for those, but you cannot receive two, quote, visits from it. There are scenarios, though, to where you can receive multiple capped rates if you're independent, or multiple all-inclusive rates if you're provider-based. So let's go over those. In the scenario where a patient comes in the morning and maybe is being seen for their chronic condition, in the afternoon, they had to come back in because they had an accident and because of the accident, maybe they hurt their leg and now they need to be seen for this condition. In that specific case, Medicare has come back to tell us that 2 separate visits would be payable. So you would want to tell us about that. Another scenario where a patient has a medical visit, and on the same day has a mental health visit, those are considered 2 visits. And then the last scenario is when a patient comes in and has the medical visit, an initial preventive physical exam, and a mental health visit all on the same day. And all of those, in that scenario, you could potentially bill 3 capped rates or 3 all-inclusive rates, dependent upon what your reimbursement rate is. So 3 8631s or 3, and I'm going to throw out an example for a provider based, of $150. 3 visits at that amount. But how do you end up telling Medicare that this is what happened? Okay, so on our example number 8, this is a patient who comes in in the morning and has their medical visit, and then come back in the afternoon because they had that accident in the afternoon. The difference here, there's 2 differences. One, we do not want to roll up charges because we want coinsurance deductible to apply to both lines. Remember, I said earlier that we want coinsurance and deductible to apply to the lines with CG. In this case, since the patient truly had 2 visits, we would put the CG modifier on both the morning visit and the afternoon visit. We would also want to use the modifier 25 to tell Medicare that we know that there are 2 evaluation and management services on this claim. The second service is separate and identifiable from the first service. You're not going to follow commercial rules for use of the 25 modifier. When you use a 25 modifier with Medicare, this is it, because we're still looking at field locators 42 through 47, we're still looking at our UB. So when you use a 25 modifier to Medicare for rural health clinic services, you are telling them that you performed 2 separate visits that day. And the secondary one was due to an accident. That's what you're telling Medicare by the use of the 25 modifier. I've had groups that, because commercial payers make you use the 25 modifier, you've done it on the Medicare claims as well. It could be that you've received an overpayment because Medicare is looking at it to say there were 2 services in one day. When you're coding your claims and trying to send it out to the commercial insurance world, they really want that 25 modifier because that's part of that rule or regulation. But that's not the same rule or regulation with Medicare as it relates to multiple visits in the same day. So that same patient, they come back another time and then they have an office visit and a mental health visit on the same day. It would be absolutely appropriate to receive 2 capped rates or 2 all-inclusive rates. Again, you do not want to roll those up, and you would want to apply CG modifiers on both individual claims. Now, you would not want to use revenue code 0521 for your psychiatric evaluation. You would want to separate it out by using your 0900 mental health code for that mental health service. So Medicare can see that patient did come in for a medical and a mental health visit on the same day. Now we have another scenario, and that other scenario is patient came in for their medical service, their initial preventive physical exam, and a mental health visit all on the same day. In this case, you would actually receive 3 capped rates or 3 all-inclusive rates. Now, there is a difference here because Medicare has told us that on the IPPE, a CG modifier is not required. Now, if you'll notice, there's no roll-ups in these claims. When we're separating out for visits, there's no roll-up. We're not adding to the top line. We're applying our CG modifier on each separate visit. But the exception is that on the GO 402, Medicare has said that a CG modifier is not required. So again, we did talk about that CG qualifier or modifier. Because coinsurance is based upon the total charge, there's no allowed amounts in rural health clinic billing on the UB. It's all based upon the line that you put the CG modifier on. So we're going to take deductible and coinsurance from that CG modifier line. Let's see, nothing really much. In this claim example, on your revenue code 521, your total charge is $100. So 20% of $100, patient's going to owe $20. That makes it kind of simple. Of course, this is a webinar that we wanted to, make things a little simple for you, right? And another example where that patient did come in and had a procedure and an office visit performed on the same day. Because of that roll up, we're going to take coinsurance from the line that has the CG, so $250 is the total charge, with coinsurance being $50, that of the $250. Under preventive services, we always want to, if you go back to a few slides ago, we said all preventive services, we want you to have those separate line items, and this is an example of that. Patient came in for their office visit and also had their IPPE exam. Medicare is going to waive coinsurance and deductible for the IPPE. And by adding it as a separate line, we're telling Medicare that we provided the service. We're not rolling it up because we want Medicare just to look at that $195 charge singly on its own. We don't want you to include it in anything else. This, it's a coinsurance based upon the procedure. I think I went backwards, so sorry about that. As it relates to influenza and pneumococcals, you do want to keep that information available. You want to keep it in your record. You will not be filing it to Medicare. You will not be informing Medicare. At the time that they do your cost reports, the individuals that do your cost report will want that detailed information with patient's name, their date of birth, the date that they had the immunization. You're going to want that information at the time that when the people do your cost reports, they're going to ask you for that information. So a lot of times what happens, we either keep a log in our area, or we run a CPT usage report from our system to pull the influenza and the pneumococcal vaccines so that we can advise Medicare and receive reimbursement for our cost. But you are not going to individually bill those to the Medicare RHC program, nor are you going to bill those to Medicare Part B. Those are only going to be reimbursed at cost based upon your cost report. Telehealth. A lot of changes in the last few days. So as part of, so I do want to go through just a couple of, a few of the regulations that are currently there. I want to try to explain what the differences are. I want to give you some codes, to look at and what you should be billing, opportunities that allow you to bill for additional services now. So if you remember, prior to the public health emergency, you were only able to bill as an originating site. You were not able to bill as a distant site. So as an originating site, you were saying the patient is located here within the rural health clinic for telehealth services. Now, this doesn't apply just to you because most of you were already an originating site, whether you're a critical access hospital, you're already an established rural health clinic. But it did allow the opportunity, effective 3/6, it does allow that the patient can be located at home. So through the public health emergency, the patient being located at home was something that's an opportunity for us. the biggest opportunity was based upon guidance that was just issued on April 30th that has a retroactive date to January the 27th of 2020 to say that providers can be rural health clinics can be a distant site. That's great information. That's good for us. We want to, be able to be a distant site so that we can provide those telehealth services. The additional guidance said that the telehealth or the RHC provider could be located within their home, providing telehealth services, almost as if as being within the walls of the rural health clinic. CMS did decrease some capabilities in provider enrollment so that we could see more patients. However, they did say that there's a consent because patient needs to know that there's coinsurance and deductible based upon these services. So we need to tell them and we need to get their consent. But that consent based upon the emergency can be obtained via verbal and documented either by the provider or can be documented by ancillary staff of the provider. But we still have to get consent, advising, the patient that we are going to provide this service. There is a responsibility that you may be responsible for. However, what also happened is to say that for telehealth services, the Office of Inspector General or the Office of Civil Rights, and both of them have kind of jumped in to say, hey, if you want to provide this service and you want to have a blanket statement that you're not going to be balance billing any patients for any telehealth, that's absolutely appropriate as well. We're not going to come back to you to say you're not balance billing the patient. So that's wrong. Medicare has said if you don't want to balance bill the patient in regards to telehealth services, that's absolutely fine as well. There was also that requirement that for you to provide telehealth services that you must you can only provide it on established patients, and they kind of opened it up to new patients. So lots of great information that allows us to kind of open things up a little bit more. There are several things that are a little bit confusing, and so we're going to go through the next probably 9 or 10 slides, some information in regards to telehealth, some additional things that were, built, advised, some confusion spots, and more specifically as it relates to a rural health clinic, and that's irregardless if you're independent or provider-based. So the first thing that's really confusing is when do I use this CS modifier? Do I have to use this CS modifier? And the CS modifier says, this is a service that's provided to a COVID-19 patient. Well, first and foremost, you need to make sure that it is a COVID-19 patient. If it is a COVID-19 patient based upon your diagnosis, then Medicare is going to say that there is no responsibility for the patient. There's going to be no coinsurance. They're going to pay it 100%. Okay. I guess a big thing, outside of the two-way real-time audio video, they now allow for telephone services. So we're going to get into those as well. It went back to all these modifiers that we're supposed to apply. Do we apply do we use a 1500 claim form? Do we bill these out? Do we use a 95? And that's where some people are having a little bit of a issue as it relates to Indiana Medicaid. There are still questions today in regards to IHCP did have a conference session today, and there's still questions in relationship to telemedicine, telehealth. I have to use both of those verbiage or both of those definitions because Medicare uses the overall telehealth, while Indiana Medicaid is just a little bit different, and they have definitions for both. So the difference is they Indiana Medicaid considers telemedicine that service or evaluation and management that's provided between the provider and the patient through telephone conversation, through obtaining vitals, obtaining information, almost mirroring an evaluation and management code there, or physical therapy eval. I mean, it kind of opens it up because there's a lot on this telehealth list that you can provide telehealth services for, and whether it be a psychiatric evaluation. So those are the evaluation and management or collection of data. The telehealth in the eyes of Indiana Medicaid would be the collection of data through the use of maybe a machine. So it's remote monitoring. So it could be that patients on a cardiac monitor and provider needs to obtain testing or data that happened on the event monitor. So patient is on a device and it continually records, and the provider will download the data based upon the device that the patient's on. So the physician's making a judgment call, not by talking to the patient, but by providing the next course of treatment based upon a device that issues kind of results of the patient's device. So with that being said, I want to make sure that I'm a little bit specific for you here in Indiana to make sure that we're using the same terminology. And so really nothing I'm going to talk about is in regards to remote monitoring, or in Indiana Medicaid's terms, telehealth. We're all going to talk about now, in Indiana Medicaid's terms, telemedicine. So I want to say that only because there is a distinction between the two services, and I would estimate, have an estimate of about 85%, 90% of the services that you're going to provide are going to be telemedicine services and not remote testing. So it gets into, what modifiers should I use? Well, we talked about the modifier CS on the line, and what we should do and what we shouldn't do. And I can tell you that at this point in time, unfortunately, CMS has issued a lot of wonderful guidance, but they need to play catch up. And in playing catch up, what they have to do is they have to modify their systems. So to do that, they've made a lot of change requests for systems modifications that will occur in July. So what happens now? If we were to submit claims in now, we may have to follow a different work plan than what we're going to have to do in July. So we're going to talk about that too. Just from the telehealth services based upon Medicare, or telemedicine based upon Indiana Medicaid, we do have to apply that consent for treatment. We do have to tell them that they're going to be responsible for co-pays or deductibles, or again, we can waive it. That's okay too. We do have to, in our documentation, we have to document where the provider's located at and where the patient's located at. We have to obviously document what occurred during the telephone conversation, what the provider observed, the findings that they had, and we would have to document the total number of minutes that our encounter took place within. If it's multiple phone calls in the same day, then you would combine all of those minutes together. So up until, I guess last week, I would have combined virtual communication services. I would have added audio or telephone call to virtual communication services. But as of the 30th, Medicare coming out to say, hey, we're going to go ahead and we're going to allow for audio only calls. Now Medicare and Indiana Medicaid are the same. So audio only is an opportunity for both Medicare and Indiana Medicaid. So if you have a telehealth service, because remember, prior to the public health emergency, providers could not be distant site providers, but now you can through the emergency. So what Medicare has done is they've said, if you've provided that real-time audio video, and that can be through FaceTime, and you're talking to your patient, and in talking to your patient, you can bill those like an office visit, only because it's audio video, it's real time. Medicare has said you can bill those, Medicare has said that you can bill those like an office visit, except for rural health clinics. We don't want you to bill those like an office visit. For rural health clinics, we want you to use this code G2025. So for rural health clinics, you're going to have one code opportunity, G2025. And that essentially says that the services were provided distant telehealth services. So some people have asked, there really hasn't been a name or a description given to that. It's my understanding that it has been given a name, and it's called distant telehealth services. You are going to use a modifier 95, and the form of that service that you're providing is going to be maybe through that FaceTime event. And that audio call, it's defined by CPT's 99441. So there are minutes attached to that. So 99441 to 443. But for rural health clinics, they said, we're not going to allow you to bill your 99441, 442, and 443. We are going to ask you to bill G2025, again, a distant telehealth service. So outside of that, there's also this virtual communication services. Well, up until the April 30th, I would have added the audio telephone call in the virtual communication services, but the public health emergency changed that so that in those two categories, the real-time audio and the audio only, you're going to bill G2025. Now, if the patient initiates an encounter with the provider, that's defined under that 99421 to 99423 CPT code. But rural health clinics, you can't use that code. Or from Medicare standpoint, if you were not a rural health clinic, you would use G0210. But for rural health clinics, you must use your G0071. So I know it's kind of a lot of CPT codes, but I want you, rural health clinics, to focus on real-time audio. Rural health clinic, use G2025. If it's an audio only, use G2025. If it's a virtual communication through the portal, rural health clinics, you're going to use G0071. So those are the three categories that you're going to have. And we're going to go ahead and get into a little bit different category. So remember I told you that CMS is really, they're providing a lot of great opportunities for rural health clinics, but they're just not, they're going to be playing catch up. So what they've told us is that here's what, when you apply the G2025, so for your audio only or your true real-time audio two-way communication, maybe through FaceTime, you're going to bill that to Medicare. Today, through June 30th, they want you to bill with the CG modifier. Remember what we talked about in CG modifiers? CG modifiers apply co-insurance and deductible. You need to talk to your billing staff because, well, you're also going to use the 95 modifier if applicable, meaning you used it through maybe your FaceTime. You're going to use revenue code 521, and then you're going to get reimbursed at your all-inclusive rate or your capped rate. So let's say yesterday you provided a service and you billed it yesterday, and you billed G2025. In 14 days, when you receive payment, you're going to receive your capped rate, your all-inclusive, or your all-inclusive rate. But Medicare says we have a guideline, and we've determined a fee schedule reimbursement for this. It is not a rural health clinic encounter, so you cannot count them as rural health clinic visits when you use G2025. We have set a reimbursement rate of $92. So from now until June 30th, you're going to get reimbursed your capped rate or your all-inclusive rate. In July, Medicare is going to go back and reprocess all those claims. And you're either going to get a positive or negative, you're either going to get a recoupment or you're going to get additional payments. Meaning, if you're a freestanding rural health clinic, you're capped at $86.31. Well, Medicare has said for rural health clinics, we're going to pay $92 for this G2025. So for independent rural health clinics, you're going to receive an additional payment. For provider-based rural health clinics, you may need to talk to your CFO, your finance individual, to say you may be getting an overpayment. So earlier in the conversation, I said that an example of a provider-based rural health clinic all-inclusive rate may be $150. Well, for all those services that you bill, you're going to get $150 until the end of, while billing until June 30th. But in July, Medicare is going to come back and they're going to do a recoupment back down to the $92. So you want to make a note that that they may be coming back. And so save some money back, provider-based rural health clinics, knowing that they're going to come back and do a recoupment. Let's see. So in July, they still want us to report our G2025. We're going to use a modifier CG, but in July, we will not be using that CG modifier. We're still going to use revenue code 521, which is a little bit different for me because 521 has always been rural health clinic services. So I don't know if this is their workaround. I don't know if in July we actually may have another revenue code. That may be something to look out for because it doesn't follow, the rural health clinic regulation. So when the pandemic is considered over, the emergency is considered over, what rules are going to change. I'm hopeful that the vast majority of these will stay the same, but we just don't know at this point in time. And it could be that next week Medicare changes some of the rules to make us pay a little bit differently. And so just bear with them. They're, again, making great changes, and we just need to play catch up, and they need to play catch up. And that we need to be paid appropriately, and we want to be paid appropriately. Now, remember when I had those audio only calls, you're going to bill G2025. So for you, rural health clinics, by billing G2025, it's irregardless of whether it's 5 minutes or 21 minutes, you're billing the same code, because Medicare wants rural health clinics to bill that G2025. But if you're billing your commercial payers and they are reimbursing for the audio only calls, you want to make sure that your time is documented, and that if you're billing for 13 minutes, you're billing the appropriate code 99422 and not the 99421 or 23. So that does make it a little bit difficult to continue to follow all their policy guidelines. I wish we just had one, but we don't. I will give information. There was through the Indiana State Medical Association, they had a call a couple of weeks ago, and there's a great decision tree if you want to go out to the Indiana State Medical Association and look for a decision tree. She has made one, and I say she, I apologize, I forget her name. It's represented through the Indiana State Medical Association. She does have a great decision tree in regards to FQHCs and rural health clinics. So Carol Hop, I think her name is. I apologize if I mispronounced that, but go ahead and look at that. That's a good resource as well. But for that virtual communication, so that's that service that maybe you're not using a portal. Maybe you have not met the definition, or really the service is not an evaluation and management service. So outside of that, Medicare has said that, I know the audio only calls are there because audio only is 5 minutes. The brief communication that maybe does not equate to an office visit or evaluation and management, we can't code it as an evaluation and management because we don't have enough documentation. Maybe we did have a check-in with the patient. With that being said, and we truly don't meet the equivalent of an evaluation and management, then we would still want to use that G0071. We can only bill it once every 7 days, and we're going to get a payment of $24.76 for that. Do I think you're going to use it a lot right now? No, because I think 5 minutes, you're going to bill that more because the audio only is available. You're going to bill more of your G2025s than you're going to do your G0071. With the pandemic, you're all familiar with the G0071 because Medicare would not allow rural health clinics to bill the G2012 or the G2010. That has always been billed by your G0071. There's no change in that, but there was change to say in the G0071, you can now see a new patient. They don't have to follow this. You have to be seen in the last 12 months. You can obtain consent at the time, and consent can be obtained by ancillary staff. Now there's those digital e-visits, which, you know, they want to focus on these are patient-initiated visits. With that, Medicare says we want you to use your G0071, and you're going to get your UB format. You're going to be doing under revenue code 521, and you're going to get your payment of $24.76, which really it increased and almost doubled in its payment. So that's good information. That's good sharing. I'm glad they did update it. Some key points that I want to talk about in relationship to telehealth is that, again, telehealth does not count as a rural health clinic encounter. And so Medicare has told us that services in relationship to telehealth services need to be separately allocated and backed out of an allowable cost on the cost report. So you need to keep information separate. That's going to be a tough hurdle because depending upon the time that you spent with the patient, you know, do I think that something will change and that they'll allow those for rural health clinic encounters? I think something has to change. Either one, you allow these to be rural health clinic encounters, or two, because rural health clinics have a productivity standard, that the productivity standard maybe during this public health emergency needs to be lowered, or during the actual year itself. So I think one of those things will need to happen, because if not, because of the fact that essential services were discontinued, most of us had cancellations or reschedules. So maybe you're not meeting the actual productivity letter, you're not meeting the productivity requirements for a rural health clinic. So I think something is going to change. It's just a matter of when. You're going to use your G2025, and don't forget that Medicare is going to be coming back in July, reprocessing those claims. So Dana, I don't know if you had a chance to look at the questions that are coming in, or I don't know if you can go over them. Are there any questions that I can answer?
We have 5.
Okay.
Can you hear me?
Yes, I can hear you.
Okay. The first one is in your example 3, if the patient is seen only for an IND and no other, and they have no other problems, do you still charge for the office visit and the incision and drainage, or just the IND?
Okay, so that's going to be my coding hat coming on. So I'm going to follow the coding rules, and I think it's dependent upon the situation. So dependent upon the situation as to what's in the documentation, how the patient presented. If the patient came in that example, it could be that the physician did need to evaluate the patient, so you could charge an office visit if it was medically necessary. If the procedure is something that requires only minimal discussion, and it's all relative to the simple incision and drainage, I would not, from a coding standpoint, charge an evaluation and management, because surgical procedure codes include a pre-operative examination, and that would be included in the preoperative. Another example of that would be when I would not charge for an office visit. A lot of times rural health clinics, they provide joint injections. So if I came in today and I told the doctor, my left knee and my right knee hurts, and the doctor says, Sharon, which one is worse? I'm going to say it's my left knee, but my right knee hurts too. He says, today, let's go ahead and do a joint injection. You tell me how it feels in 2 weeks. And based upon how it feels, you can come back and get the right one done. In that scenario, I am not going to charge another evaluation and management in 2 weeks, because today, when I got me a joint injection, I got the joint injection. I also got charged an office visit. In 2 weeks, I call back in and say, I want to be seen because I want a joint injection of, my other knee, because that one helped tremendously. I would not charge a second evaluation and management code, because the physician did already evaluate me and determine my course of treatment. So it's it depends. But in the example that I gave, if it's a simple incision and drainage, unless there's something else going on, I would only charge for the procedure code. But again, it's based upon the documentation.
Okay, the next question is about modifier CS for COVID. And so the listener was under the impression that not only that you don't necessarily have to have the COVID diagnosis, it could also be used if you performed, ordered, or were trying to figure out if the test is needed.
Yeah.
Could you comment on that?
Well, CMS has said that. However, in all of the documentation that I'm seeing, they have to have the COVID diagnosis. Now, I can say that COVID was ordered, and in doing that, you would have that documentation in your chart. You would use a CS modifier. I don't know if that's going to get a 100% reimbursement, because from what I'm seeing, there's a discrepancy against the payers, the max, in what they're paying. So Medicare, we have expressed that to Medicare, and I know through the Indiana Hospital Association, we have a call tomorrow. The use of that modifier CS, and when it should be used, when it should not be used, when am I going to receive 100% payment? From what I know at this moment, it's going to be reimbursable on a patient who has COVID. Now, there may be additional guidance, and again, Indiana Hospital Association has a call with CMS tomorrow, and it is something I will be specifically bringing up, and that maybe they do a special edition article on CS modifier. And I know other states have had issues as well, questioning the same thing. So I do look forward to seeing additional information coming back from CMS on the application of the CS modifier. So look forward to that.
Okay, and code for if the patient is in the nursing home and they're usually visited in the nursing home, is the revenue code 521 or something else?
Mm-hmm. No, it would be something else. So if they're in the nursing home, that would be under the 524, 525. Which one is that? 524, 525 in the nursing home. But here's my validation. Some people say, well, I've never billed that as a nursing home visit as a rural health clinic visit.
Did I mention it's telehealth visit?
Oh, telehealth.
I'm sorry.
So
Telehealth.
is it audio only? If that's the case, then you're going to go against your G2025. That's not going to be a true RHC visit. Did I answer the question or no?
Okay, let me try again just to make sure I got it clear. A patient in the nursing home, they're billing G2025, and so the revenue code, would that be 0521 or something else they are normally seen in the nursing home?
Well, based upon guidance at this point in time, since I'm using G2025, I would use revenue code 521. But I understand that that would be a question for the nursing home, because normally I would be using 524 or 525, but since this is telehealth, they've instructed 521.
Okay, and the next one is, do you know whether the Medicare Advantage plans accept G2025?
I don't know yet. I haven't heard. I can tell you that there was a call with Indiana Medicaid today in regards to COVID questions. So I can't answer the Medicare Advantage, but I can answer through the Indiana Medicaid call. Someone did bring that up in regards to Indiana Medicaid covering G2025 for crossovers. So I did send them information to allow in their bulletin BT 2020-56, and which is automatic crossovers. I did specifically request that they add G2025 and G0071 to that automatic crossover list from Medicare. So I don't know about Medicare Advantage. I apologize, but I can tell you about Indiana Medicaid and what I did today to see if we could get those automatically covered for crossovers.
And the last question I haven't checked the chats, that was the Q&As. Where can we find the decision tree? I don't know if you could get that later.
I can actually look it up, and then Dana, I can send it to you, and then you can send it out. Is that okay?
Sure.
Okay.
Because everyone's going to get an email.
Yeah. So again, that was there was a great webinar, and I don't even know if they have it listed on the Indiana State Medical Association website, but it is a very good decision tree. So, and I want to give kudos to, I think it's Carol Hop. I don't know, but she'll get kudos from you sending it to her, to the rest of the group.
And I think all the chats were technical or answered.
Okay. All right. Well, this is my email address.
Wait a minute. Wait a minute. Jim did write, how is allowable cost determined? What is the numerator and what is the denominator?
Goodness. Well, in its basic form, It's the number of visits divided by expenses, and whatever those expenses are. And that could be staff expenses, that could be supply expenses. What are your expenses? That's why I'm saying it's going to be tough to separate out the rural health clinic services, because that means that if I'm a medical assistant and I'm taking 5 minutes, 12 minutes and having a conversation, and then I'm including in the practitioner, they're saying, wait a minute, those are not rural health clinic services, so it needs to be backed out of the cost report. So all of this time in this example would have to be backed out. So that means that I'm going to have to keep a log of how much time that I have and the resources that are used in providing that service. So I think it's going to be a challenging one. And I think that, Jim, I think that what they're going to do is, when the reimbursement people get that, they're going to take expenses, or average expenses probably, of a category of an individual. So if I'm a medical assistant, and I'm just going to throw out a number, I make $14 an hour, and I'm another medical assistant and I make $14.25, and I'm another one and I make $14.80. They're going to take, I assume that they're going to take the average of that. So there's going to be a lot of calculations in that, and they're going to ask for a lot of information at cost report time.
Okay, I think that gets all our questions. And again, thank you so very much, Sharon.
Oh, thank you.
Gave a lot of good information today. And thank you all for being with us today. It was a longer webinar than usual. We appreciate your time. Thank you so much. And this is the end.